So next is papilledema. When we say papilledema, I told you disc edema. Papilledema means or is equal to disc edema due to increased intracranial pressure. Okay. So this definition is absolutely not negotiable. All patients with papilledema means that they have disc edema due to increased intracranial pressure. So pathogenesis is there are many pathogens believed to occur due to axoplasmic stasis within the venous congestion in the optic disc because of increased intracranial pressure. But what is important to the ophthalmologist is the stages. Stages of papilledema can be early papilledema, then you can have established papilledema, you can have chronic papilledema, or you can have the atrophic stage. So stages can be the following. So when you say early papilledema, you're talking about the disc edema, which is barely visible, but in established papilledema, the patient has a clear-cut disc edema, and they can also have a surrounding peripapillary edema. So this is what you're seeing as whitish areas is actually surrounding peripapillary edema, and these areas that you're seeing here are the cotton wool spots. So cotton wool spots is suggestive of ischemia. So this is all these are features of established papilledema. So you'll have a highly elevated disc, you'll have an obscuration of the cup. That means the disc is so elevated, there is so much of congestion. You'll have cotton wool spots suggestive of ischemia. Another important feature is venous dilatation and tortuosity. All the veins, you can see these veins are even tortuous. So venous dilatation and tortuosity, you can see hemorrhages here. So these hemorrhages are a feature of established papilledema, and this black arrow that's pointing to this area, you can see the arrangement of the exudates. So this is called a macular fan. This arrangement like this is called a macular fan. This macular fan arrangement is again classical of papilledema, and once you have seen this, you know that at this point the patient has had transient blurring episodes. So what is the type of visual loss in these patients? You have transient blurring episodes. Then you have chronic papilledema. So what is chronic papilledema? Here you have patients will have what you call Patens lines, that is demarcation of edematous areas. So these are called Patens lines, and you can also, the patient can also start developing visual field defects. The classical visual field defects in patients with papilledema are enlargement of the blind spot and peripheral constriction of fields. So these peripheral constriction comes later, but enlargement of the blind spot is one of the most important features. And in the atrophic stage, the patient can go on to develop optic atrophy, and this optic atrophy in these patients is typically what we call secondary optic atrophy. Tumors of the optic nerve is another very important cause, because it can be, it is explained under compressive optic neuropathy. So what exactly are we talking about when we say compressive optic neuropathy? So optic nerve glioma and optic nerve sheath meningioma is explained as the causes of compressive optic neuropathy. When we say optic nerve glioma, the lesion is at the optic nerve itself. When we say optic nerve sheath meningioma, we are talking about the nerve sheath, the sheath that surrounds the optic nerve. So here is a patient with an optic nerve sheath meningioma, and optic nerve sheath meningioma classically occurs in middle age. It is more common in women. So this optic nerve, so in this picture, we are seeing that this is an external photograph. You can see that the patient has a well-centered pupillary reflex, but you can see that the left eye of the patient appears to be more prominent than the right eye of the patient, and this prominence of the left eye is probably because this patient has some mass which is pushing the globe forward, which is the reason why the patient has the proptosis. So proptosis is classically seen in the left eye of this patient. Now, a patient who has optic nerve sheath meningioma can have, along with proptosis, some other features. So they can have decreased visual acuity, and they also have something very important which is called optociliary shunts. So optociliary shunts is one of the classical features of optic nerve sheath meningioma. But when you do an MRI for these patients, you have what we see here as a tram track, that is both sides of the optic nerve, that is optic sheath, is getting prominent and enhanced, and that is called a tram track appearance of the optic nerve, which is again classical of optic nerve sheath meningioma. And apart from that, you can also look for calcification. So these are the two features. One is tram track appearance and the second is calcification. These are the two features we need to look for in a patient who has optic nerve sheath meningioma. CT is also one of the preferred investigations in patients with orbital defects. But the difference between CT and MRI is MRI will tell us about the soft tissue lesions better, whereas CT will tell us about the bony lesions better.